This is our PowerPoint presentation on celiac disease by Erica Hoodoff, Jennifer Scott, Lindsay Casper, Ashley Pascoe, Stephanie Wolpert, and Brianne Hankins.
What is celiac disease? Celiac disease, also known as celiac sprue and gluten-sensitive enteropathy, is an immune-mediated disorder triggered by ingestion of gluten-containing grains, also including wheat, barley, and rye. And celiac disease is a genetic autoimmune disease that damages the villi of the small intestine and interferes with absorption of the nutrients from food. According to Riddle, Murray, and Porter, 2012, several factors are hypothesized as possible disease triggers, including intercurrent illnesses such as gastroenteritis, surgeries, and trauma. Has the incidence of celiac disease increased or decreased over the years? The incidence of celiac disease increased fivefold from 1.3 per 100,000 in 1999 to 6.5 per 100,000 in 2008, with the highest rates of increase among those over 34 years of age, which is the average annual increase of 0.8 cases per 100,000, according to Riddle, Murray, and Porter. Prevalence. What is the prevalence of celiac disease? Celiac disease was considered to be a rare malabsorption syndrome that manifested during early childhood, but today it is known to be one of the most common genetic diseases, with a mean prevalence of 1% to 6% in the general population.
The exact etiology of celiac disease is unknown at this point. What we do know is that almost all people with the disorder have the MHC class 2 HLA, DQ2 or DQ8 allele. They're all affected by the environmental trigger of gluten, and when they ingest the gluten, their body creates an autoimmune response involving tissue transglutaminase. Not all people that have those specific HLA alleles actually have celiac disease. Some other things that can contribute to the development are early infection with viruses, timing of when a child was introduced to wheat. If it was either really early or really late in life, they can have a predisposition. And also gastroenteritis, whether it's viral or bacterial, can increase the permeability of the small intestines and release more of the tissue glutaminase, which creates that autoimmune response. Celiac disease results from the inappropriate T-cell mediated immune response against ingested gluten, which causes an inflammatory reaction resulting in loss of absorbed villi from the small intestine, which causes or may cause malabsorption. The pathophysiology is basically an immune reaction or response, which we learned about a few weeks ago, but we'll walk through it right now. When gluten enters the body, the tissue transglutaminase breaks it down into peptides, which helps to increase the peptide's affinity to bind with the HLA DQ2 or DQ8 molecules. Once the peptides bind with those molecules, they're presented to CD4 T cells, which produce cytokines and induce the inflammatory cascade that results in the intestinal inflammation, causing the villus atrophy, hyperplasia, and infiltration of the inflammatory cells, which results in the malabsorption. There's also autoantibodies that are produced in this process. This picture here just represents a visual of the process we just talked about. You can see where the gluten comes in through the small intestines, reacts with the TG2 or the transglutaminase, which breaks it down into the gluten peptides, which are bonded with the HLA DQ2 or DQ8 cells, which present them to the CD4 T cells, which creates the Th1 cells causing the destruction of the villi, and also B cells that produce the antibodies against the gluten, and Tg2. Those autoantibodies then are released into the tissue or enter into the bloodstream. You can see up at the top too where the non-gluten containing components stimulate the native immunity in the macrophages and dendritic cells, which activate the intraepithelial lymphocytes. So there's a few different things going on in this picture to explain the overall pathogenesis of celiac disease. Celiac disease can present at different times throughout the life. In infancy, it's the most dramatic or most serious. Infants will present with failure to thrive, diarrhea, muscle wasting, abdominal distension, and even severe malnutrition. In early or even later childhood, the symptoms are a little less severe. They may present with anemia, short stature, enamel defects, or constipation. As adults, celiac disease often goes undiagnosed because the symptoms are so subtle. Presenting symptoms include GI symptoms, including abdominal pain, diarrhea, bloating, excessive gas, or constipation. Vitamin deficiencies due to the malabsorption of fats. Vitamin D deficiency is a more severe symptom, but also from malabsorption. And then also anemia secondary to iron and or folate deficiency related to, again, the malabsorption.
Physical exam findings of celiac disease in an infant include weight loss or an inability to gain weight. The infant may be short, thin, and listless. They may have abdominal pain and bloating, as well as poor immune and organ function due to malnutrition and a failure to thrive. Children may be pale due to anemia, and they may have growth failure accompanied by dental and bone defects due to malnutrition. Again, they may have abdominal pain and bloating. Adults also have abdominal pain and bloating. They too may be pale and thin. Of note is an increased incidence of celiac sprue in individuals with Turner's and Down syndrome. Those are both chromosomal abnormalities. Additionally, there is an increased incidence in people with dermatitis herpetiformis, which is a chronic blistering condition of the skin. The following is a case scenario for an individual with celiac disease, including common presenting symptoms and physical exam findings. A 22-year-old female patient reports increased postprandial abdominal pain, a 5-pound unintentional weight loss over the last 3 months, change in bowel habits with diarrhea and increased stool frequency, and generalized malaise. The patient denies medication changes, blood in her stool, exposure to unclean water source, recent international travel, or fever. The clinician, upon physical exam, would note abdominal bloating and tenderness with palpation. There would be an increased resonant sound with percussion. The patient's bowel sounds would likely be normal, and the clinician would note that the patient is pale and thin. Celiac disease is the most common cause of villus atrophy. You can see healthy, normal, plump villi in the photo on the left and compare that to flattened, blunted, and scalloped villi in the photo on the right. There are several possible causes for villus atrophy in light of negative celiac disease serology. These are listed below in order of commonality according to a research study done by Degitt, Tani, and colleagues. The differential diagnoses include seronegative celiac disease, medication-related villus atrophy, unclassified sprue, common variable immunodeficiency, and autoimmune enteropathy. The list continues on the next slide. To continue from the previous slide, other causes of villus atrophy in patients with negative celiac serologies include Giardia, CD4, small intestinal T-cell lymphoma, tropical sprue, small intestinal bacteria overgrowth, collagenous sprue, enteropathy-associated T-cell lymphoma, Crohn's disease, and extensive gastric metaplasia. The graph on this slide shows each of these diseases and their likelihood of incidence. And again, these diseases were listed from most common to least common. Duodenal biopsy is the gold standard for diagnosing celiac disease. It is obtained through an EGD scope and tissue biopsy in the duodenum. Celiac disease will show decreased folds in the duodenum accompanied by scalloping and blunting of the villi. That is portrayed in the picture on the right compared to the normal healthy villi on the left. Serology testing for celiac disease includes an immunoglobulin A anti-tissue transglutaminase antibody, also referred to as TTG-IgA. This test is sensitive for untreated celiac disease. It is 95% specific and 95% sensitive. TTG-IgA is the preferred single test for individuals over the age of 2. A negative TTG-IgA may be false if the patient is deficient in IgA. To confirm IgA deficiency, a total IgA may be ordered. IgA deficiency is more common in celiac disease than in the general population. It occurs in about 2 to 3% of patients with celiac sprue. If the patient is IgA deficient, then IgG testing should be performed, which includes IgG GDPs and IgG TTG. It is very important that all diagnostic testing be done with patients on a gluten-containing diet, otherwise the test results are inaccurate. Additional lab tests may be ordered to determine whether celiac disease has resulted in nutritional deficiencies. So, for example, there may be vitamin deficiencies due to fat malabsorption. Vitamin D deficiency could cause rickets or hypocalcemia. And then there may be anemia secondary to iron and or folate deficiencies.
Coming to a diagnosis, children. Histological diagnosis is considered gold standard for children. Oftentimes, symptom recognition is the first sign of celiac disease in children. From there, you do serological screenings, which includes the TG titers and IgA levels. If histology positive, they often recommend a small bowel biopsy, which can confirm a diagnosis of celiac disease. Also, positive HLA-DQ2 and HLA-DQ8, along with serological screenings, have a high predicative value for diagnosing children. The HLA-DQ2 and HLA-DQ8 have been linked with genetic background for celiac disease. It is important that these children must remain on a gluten diet until testing is completed. Coming to a diagnosis, adults. IgA anti-tissue transglutaminase antibody is the preferred single blood test for adults. Antibody screens and titers are good indicators. However, diagnosis is confirmed with multiple findings, including history, physical exam, serology, upper endoscopy, most important, positive small intestinal biopsy, and clinical response to change in gluten-free diet. Okay, guys, for the questions. Number 1, celiac disease is an immune-mediated disorder that is triggered by the ingestion of A, rye, B, barley, C, white bread, D, A and C only, or E, A and B only. Well, if you choose A and B only, you got her. Number 2, signs and symptoms of celiac disease would include all of the following except A, chronic diarrhea, B, bloating, C, prepandial abdominal pain,
D, weight loss, or E, pale skin? Well, if you answered C, that's correct. Number 3, the etiology of celiac disease includes all the following except A, early infection with viruses, B, timing of wheat/gluten introduction, C, exact cause has not been identified, D, immunologic autoimmune involving tissue transglutaminase, or E, MHC class 1 HLA DQ2/HLA DQ8. Well, if you answered E, that is correct. Number 4, Jimmy is 4 years old and his mom brings him into the clinic to see you. He has been showing signs of weight loss, abdominal pain, bloating, and diarrhea. Mom reports that he always has belly pain after he eats. Preliminary lab tests were drawn to help determine a diagnosis. The FMP ordered the following tests except A, CBC, B, folic acid, C, vitamin B12, D, iron, E, C, reactive protein. If you answered E, great job. All right, last one. In order to diagnose an individual with celiac disease, which is the most important to confirm the diagnosis? A, history, B, physical exam, C, upper endoscopy with a positive small intestinal biopsy, D, clinical response to a change in a gluten-free diet, or E, all of the above. Well, if you answered C, you got it. I'm sure you all got 100% on this. And here are our references for our whole PowerPoint presentation. Thank you all for listening and have a great day.